So I have my dad, he's my patient, he's in the chart, I just need to get the chart and then also he has his x-rays done, but the office has been on break for like the past couple of weeks, so I haven't been able to get him sent over.
What's up, bro?
So they're back today.
You gotta come up with our own handshake, bro.
It doesn't take long for it to
Who's that? We need to be creative every day.
Good. I've been freaking out about this. Like, I've been trying to call them, and it's literally been like the past 2 weeks. So.
I'm back from spring break. I'm back. Right?
Yeah. Okay. Good.
All right.
Thank you.
So can you get on that Zoom right now?
Yes.
What happened?
It's a motorized
Okay. With the red carpet?
So Aileen,
That's pretty cool. Is that Lady Gaga? Mm-hmm. That's pretty cool.
That thing only can be achieved with that much.
Oh,
Take this one, bro. The Jennifer Lopez one.
Okay. I get it.
that's cool.
That makes sense.
Amazing.
Yeah.
I need it.
That's technology, bro.
okay.
You want to move over one?
So you're telling me nobody has their adult
Okay.
presentation in the morning?
Oh, me. I put my little guy there. Oh, wait.
Oh, good. I do see it. Sorry. Everybody but Catalina has their patient in the afternoon. Can you pass that up to Nelly for me? Wake up. Okay, so if anybody else has their patient in the morning,
Oh, I know.
pass that around. I want to get that down.
I'm still waiting for him to fill
So I at least know I don't have many patients in the morning. So if you do not have clinic scheduled for tomorrow morning, do we have floaters scheduled on each clinic day?
Yeah.
Okay. Then as long as there are enough floaters to cover the first adult prophy people, you should be okay to not come. But in the afternoon, all hands on deck. Everybody who's here. Okay. I got Kevin, still waiting on the other person who was with Mrs. Ellington to know who they were. So my choices are Hannah Grandel and Adrienne Carrillo. So did Mrs. Ellington fill out one for you? Okay. And then who did you work with yesterday? I mean, last week. Seems like yesterday somewhere. Seems like a month ago somewhere.
She worked with this. Last? Yeah. Hey.
Okay, we'll get together with her this afternoon. Nope. All right. All right, try to keep up on the paperwork. It's better when we get in the swing of things. All right. Put SH. Okay. So, let's get to this. All right. I know you saw this already because it's posted. I think it's hilarious.
That's good.
Okay. So the serious side of this is did anybody have orthodontics have a retainer and oh my dog, your dog loved your retainer and it was really expensive? Same thing can happen with dentures. Ooh, my master saliva, the best thing ever. So, having the patients keep their prosthesis in a safe place is important. All right, so we want you to be able to list the components of a complete denture and a removable partial denture, how to insert and remove it in case you have to, compare and contrast a complete denture with an overdenture, describe the care of all these things, and what kind of home care instructions you're going to give the patient. So, why do we lose teeth? Could be caries, could be periodontal disease. Tobacco use absolutely contributes greatly to tooth loss. Increases risk of caries and greatly increases your risk of periodontal disease. Low socioeconomic status. Not only is somebody at risk for more dental oral disease if they're low socioeconomic status, when they do get that disease, they have less resources to cope with it. So they're more likely to have lost teeth. Inadequate access to oral care. Low frequency of professional oral care, poor daily oral hygiene. So all those things are important. So, oh, I'm so sorry. So, why do we want to replace these guys? So I know in oral anatomy you guys talked about super eruption and inversion of the teeth, having things drift. So that is the deal. Is if you are missing teeth, then Mother Nature's orthodontia tries to fill the hole. Okay, scooch forward, everybody behind this. Keep moving. Let's fill this hole, right? So they'll lean over. Was good direction. Stay with me. Teeth that do not have opposing occlusion will tend to super erupt. It's not just that upper teeth fall down. Lower teeth will super erupt up towards the maxillary. And really typical that teeth will drift in an anterior direction if you lose a tooth.
Yeah.
Okay, all right. So, that's not the way God designed the teeth to work together. So, if the teeth are malposed, then you start having a deeper pocket around this tooth, and a deeper pocket on the front of that tooth, and a deeper pocket on the mesial of this tooth. When the teeth are not at the angle they're designed to function in, then the forces are being put on the root at an angle instead of more straight along the length of the longitudinal axis of the tooth, right? And so all of those things can contribute to further destruction of the periodontium and of the teeth. And then just in general, if they lose a lot of back molars, guess what? They lose what's called vertical dimension. So, the old person, is the chin meeting the tip of their nose, right? It's because you're losing vertical dimension. This can happen just with wear on the occlusals, but for sure if those teeth are gone in the posterior, we got a big problem. So it's this kind of look. Right, so this can be really devastating for a patient, obviously, for their self-image. So, they look in the mirror, they think, I'm old, I'm not sexy anymore. Feeling really insecure, really a great loss of self-esteem. So some patients will be really reluctant to ever take their dentures out. I certainly have treated probably 3 women who, like the dentist, really had a hard time getting a look in their mouth without the dentures in. So that was real interesting. I could have them take their denture out, I could do their EOIO, and then while I was doing that, quickly clean it for them, and then it had to go back in before the dentist came in one particular case. That's how bad she felt. So that's a problem. Another trouble with trying to replace teeth is like, oh my gosh, these teeth are so much trouble. I give up. They have the teeth taken out that they were struggling with. The dentures go in, and it's like I said, my husband's aunt was just like, wow, it's like having two frying pans in my mouth. Things are kind of flopping around, and nothing's, it just feels bizarre. because I have these two prostheses that are not part of my body I'm trying to do a really critical function with. As I say, the teeth are the only reason the alveolar bone is there, right? As soon as you take teeth out, you start losing alveolar bone and losing that ridge. And really relying on that ridge to be able to support the dentures. So, here's the thing. Especially postmenopausal women, because mostly this happens to older people, lose probably twice as much ridge per year as men. But men eventually do lose the ridge as well. So, the ridge resorbs a couple of millimeters usually the first year, and then half to 1 millimeter per year after that on average. But if you have osteoporosis, it's going to be faster. The oral mucous membrane changes. You don't have attached gingiva around the teeth anymore. So now, let's take this not very keratinized tissue and smush it between the whole hunk of plastic and your bone, because that'll be really comfy.
Why are women's teeth times faster?
Because when we lose estrogen, we start losing bone density. And then the loss of muscle tone. So losing that alveolar resorption, we can get exostoses or tori that can create undesirable consequences, but it just really shifts how your muscles work too. And the way that the dentures are in your mouth can actually be really challenging. So if you have a denture, or especially a set of dentures, and you're trying to take a bite of an apple, what do you think happens? They pop out, right? So you've heard this from patients, right? They had to relearn how to eat.
They couldn't kiss either.
They couldn't kiss either,
Like, I can't
Well, that's so.
Teeth inside out.
right? I can't kiss you with these things in, and I feel like I look like that if they're out. Yeah, that's not good.
Popeye.
So if the patient is going to eat an apple and they just bite, then the back of the upper denture will pop down and the back of the mandibular denture will pop up. And now you got two giant pieces of plastic floating around in your mouth. So people wind up having to cut up foods. They may just switch from fresh vegetables and things to stuff that's soft all the time, so it impacts their nutrition. And they have to actually learn. So if you're going to eat an apple and you have an upper denture, but you have a lower partial, you're in better shape because that lower will usually stay in. But you learn to actually take the apple and shove against the denture up and back so that the denture will stay in to be able to take a bite of apple. It's a whole different strategy. So none of those things are good. So you're losing a lot of bone that supports your face, contours your face, really change your appearance. And this is that loss of face height, like your chin and your nose are going to meet. You don't have as much lip support, right? We're so crazy about lips on women that we do crazy things of injecting stuff, foreign bodies into them. So now, oh gosh, you lost your lips. Having that sunken maxillary appearance, you tend to get a lot of wrinkles across your upper lip. Oh my gosh, all the fillers in the world are not going to fix that. And then that increased chin prominence. Really tough to talk without the teeth in there. What do you know?
With the loss of vertical, does that have an effect on their TMJ as well?
Can have an effect on their TMJ.
Like painful or just like?
It's weird, and they sometimes do wind up with TMJ issues. So after a while, people do learn to speak with the dentures in, but there's quite the science of having enough what's called freeway space so that they're not kind of whistly and lispy all the time, making the teeth long enough, but not too long yet. Anybody who can make awesome dentures is just kind of a dental god in my estimation, and I'm glad you can do that. Like, you wouldn't want to do hygiene, and I'm awesome at that, and thank God we have somebody who makes good dentures, hopefully. But masticatory efficiency, even with a great denture, is the big problem. So because you lose the support and the proprioception, where are my teeth in relationship to the rest of my face, your biting force, that being able to bite into that apple, decreases tenfold, and your chewing force is reduced threefold. So 1/3 the biting, or 1/3 the chewing force, and 1/10 of the biting force. So that makes a really big impact on nutrition for patients. and your enjoyment of food. Problems with the oral mucosa. Lots of times this is happening to people who are older, who have more diseases. And anytime you have a dry mouth, it tends to make your tissue more sensitive, more prone to injury. And so that tissue underneath the denture can be really, really painful. You have decreased tolerance to stress, impaired healing, the emotional strain of going through all this, the medications related to poor systemic health, all that not only has an effect on caries risk from the dry mouth and things like that, but now you have the 2 plastic frying pans in your mouth and your mouth is really dry. Really, I have to do that too, right? Everything's kind of sticking together in there. And so cortisone, thyroid hormone, estrogen, blood pressure medications. Think about the medications in pharmacology. How many of the top 200 meds cause xerostomia in the U.S.? Everything, right? Everything causes xerostomia. So, sometimes people lose teeth because they have oral cancer and we had to remove chunks of their body. And then we had to remove other chunks of their body because we were going to shoot radiation through them and we knew that the teeth wouldn't survive. Right? So now they have no saliva because we irradiated their salivary glands. The saliva is actually what's going to make the suction on the ridge or the palate to be able to keep the denture in, and lubrication, cushioning, and so when you lose that saliva, that's a really big problem. And so you get frictional irritation. You definitely can have the cracked lips, fissured tongue, burning mouth syndrome, because you have a greater risk of having the candidiasis that often causes burning mouth syndrome. Altered taste perception. So, 2 things. 1, just from xerostomia, because you're not juicy anymore, you don't get good dissolving of the components of your diet into a form that will actually trigger the electrical impulses of your taste buds to taste anything. So reduced taste sensation when you have xerostomia anyway. Now we put the giant plastic frying pan on your palate. Guess what? Your palate actually has a lot of taste buds. And so your perception of taste goes way down. So now, not only are you struggling to chew the food, but you can't taste it either. So, it's not good. The amount of salt and sugar that people, because that's one of the things you can still taste, sour things, right? So they have a partial and a denture, and they can't taste anything, so they're having lemon drops to try to keep their mouth moist and taste anything. So the other teeth will melt away because sugar plus acid, right? So it's just a whole can of worms. When we get to this point, it just tends to accelerate the destruction we're seeing. So we really, really need to intervene with them and really, really beef up all those preventive factors that are going to preserve the rest of the teeth they have if they do have teeth. All right, so the state of the ridges directly affects the comfort of the removable, partial, and the full dentures. So sometimes, it's like, okay, if you had to walk barefoot on rocks all the time, your bottom of your feet would be unhappy. So there are times then we will put a little cushy lining on the inside of the denture to try to make it better. So tissue conditioner, a temporary soft liner would be like a little, shoe insert that's really cushy. They wear out after a while, you throw them away, you get a new one, you put it on. The liner, some of the soft liners actually are more permanent. They actually are applied permanently to the denture, and hopefully the patient can take good care of them, and they will last for a good long time. But with these softer liners, they tend to accumulate more biofilm, so they can have more halitosis, just overall biofilm, bad taste, and then increases the risk of Candida albicans compared to the really hard acrylic surface of the regular denture. So, types of prostheses. You guys have really thought about fixed denture, partial dentures, so that would be a bridge. Also, we do periodontal splits. So remember the picture we had of the teeth had lots of attachment loss, and the composite little splint that held everything together, glued, tooth 1 to 2 and 2 to 3 and 3 to 4, and okay, together we're going to hang in here, reduce the mobility. There are implant-supported complete and partial dentures. Right, so instead of sawing down the teeth on either side, especially if we're losing a lot of teeth, then we're doing way more. Let's just put some implants in there and put a denture on that. Cool thing, you don't have to destroy the adjacent teeth. Plus, if something goes wrong, we take them out, we do a little bone graft, we do it over. But also, orthodontic appliances fall into this care of removable prostheses and removable, orthodontic appliances, the fixed ones, we have to talk about worrying about good biofilm removal around those, and then cemented space retainers. Right, so we're going to do special oral hygiene instruction for any of these patients. Removable, we're talking removable partial denture. So this is going to be attached some way in the mouth. It may be natural tooth support, it may be implant support. So that's why I was, the fixed ones, we'll put a couple of implants in there and do a cemented bridge, or attached with screws sometimes. The implant supported is going to be usually a partial, usually the patient only has a few teeth left, or they may have no teeth left. And they're actually going to be able to take that removable denture in and out. Complete denture, which just is not supported by anything but the patient's tissue. An obturator is an appliance that actually goes into the mouth to fill a void. So, really common, it used to be really common with cleft palate, that if we couldn't do a surgery early enough to be able to close the hole in the palate between their mouth and their sinuses, their nasal cavity, that we would do a temporary retainer or partial denture kind of thing that would fill that hole. Sometimes patients who have oral cancer wind up losing a chunk of their body, and we have to fill that in with some sort of obturator to be able to get them reasonable function again. They may have removable orthodontic appliances that we still have to teach them to clean around. A removable space maintainer or a Holly appliance, that's a retainer also that, removable orthodontic appliances. This Holly would be the retainer. Sometimes patients will actually have, when we're trying to maximize their growth, they'll actually have two retainer type things that actually lock together and increase jaw growth. So you get as much jaw length as possible to spread out the teeth that you have and have a little more available space. So making sure that they can take care of that and not damage it is really important. All right, so definition of prosthesis is a replacement part. More than one prosthesis is prostheses. Edentulous, they don't have any teeth, partially edentulous, some or most of their teeth are missing. A complete denture will sometimes be called a CD, so if you see CD in the notes, complete denture. It's not an old-fashioned way to listen to music. It's going to replace all of the dentition in that arch, right? All the teeth in that arch are missing. A removable partial denture replaces some of the dentition, and then both these things obviously are removable. An immediate denture, which is what my husband's aunt had, was we take impressions, we make a denture the best we can from those impressions, like they cut the teeth off and they make the denture over that. And then as soon as they take the teeth out and we get the bleeding controlled, then they put the denture in. It works partly as a bandage. It partly helps to mold the way the ridge is going to be. Let's do surgery and then put a plastic thing over it. Really comfortable? No, right? But it is useful for some people, and it's better for sure for somebody who, has a job. Like, okay, I'm getting my teeth extracted by Friday. I can't take 3 weeks off till they make a denture for me. Just being able to show up to work, the few days or a week later and actually have teeth is a good deal. But it's not necessarily very fun. The obturator, as I say, it's got an area that extends into a defect, and it's going to close the defect so the patient can eat, speak, swallow without drowning. Fixed partial denture we talked about. Interim prosthesis We may, if we, for instance, extract a tooth, we may give them what's called a flipper. Anybody heard that? Why do we call them a flipper? Because they flip around. It's like, it's usually maxillary anterior teeth they do this on. And so it's like a little retainer, and it'll have the 1 or 2 teeth, whatever it is, on it, and they tend to pop out, and often at inconvenient moments. So, if, for instance, somebody's congenitally missing laterals, maxillary laterals, they may have a flipper to help hold the space open. And for aesthetics, when they're a kid and when they're ready for orthodontia, then they will actually often add a little false denture tooth to the wire, and they'll have teeth in their teeth that are going to be, aesthetically functioning. They're not going to necessarily work at all for occlusion. But in the meantime, they'll have this little interim thing. And then implants. The titanium post is anchored to the bone. Crowns, bridges, or dentures then can be custom made to attach the implant. All right. So, risks of caries and periodontal infection increases because the biofilm attaches to the irregularities of the restorations, under the clasps, and around the fixed prostheses. So patients will think, well, it's not teeth, so it's not going to get calculus. But guess what? There you go. How well, by the way, is this fitting? Not great, right? So I'm thinking that they lost ridge here, and it is sunken in and pulled away from this canine. So that's one of our things we're going to do is check with the patient. How does it feel to you? And we're also going to do a little visual survey and say, hey, how does this look to me? Do I think I need the boss to come and look at this and decide what's going on? All right. So, because this is already a high-risk patient, or maybe extreme risk, plus putting this big old piece of hardware in their mouth just made things worse as far as maintenance, we've really got to educate the patient on taking care of things. And that daily maintenance is just absolutely critical to the success of this. We don't want to blow out the rest of their teeth, and we want that prosthesis to function as comfortably as possible for them and last as long as possible, because they ain't cheap. So we're going to talk about taking care of their natural teeth, taking care of their soft tissues, and taking care of this appliance, this prosthesis that we've made for them. All right, so the fixed partial denture, pretty familiar with this, right? So you've got the really conventional one. We grind down this tooth and grind down that tooth, take an impression, or these days do a scan, and cast or machine bridge. So 2 regular crowns on the abutment teeth, retainer or abutment teeth, and then the pontic in the middle, so like a pontoon bridge, that's the part that links them together. Or, say the person loses their molars, because frications are challenging, right? So they lost their molars, but they still have their single-rooted teeth. But we really would like some first molar occlusion, and the patient does not want something removable. Then sometimes we will do a double abutment on here, and the pontic hanging off the end. And this is a cantilever. It's cantilevered out over space. So when you bite on this, what's going to happen? So it's going to put a lot of force here on this little cantilevered pontic. So you notice it's not a giant molar shape. It's pretty small. It is going to stress out these 2 teeth more than normal. So if they have good bone support, then that's great. But we just need to be aware we can't make it a giant tooth, and we have to be really aware of those forces. We got to really check the margins all the time, because these guys tend to open up quicker and need to be replaced more often. Back to the more conventional deal, we can do a posterior and anterior implant abutment and the pontic in between, and these guys tend to be really, really stable. And like I was saying, here's the deal. If they fail, it's not cheap and it's not fun, but we can actually just remove these guys, do a bone graft, and actually redo the procedure. And we don't have to grind down any existing healthy teeth if they have them next door. Those get to stay. So we're doing a lot more of that. And before we had implants, we also did this Maryland bridge kind of thing. So a whole bunch of different kinds of attachments, but basically it is, we're not going to grind down the teeth. We're just going to glue attachment on one side and the other side and hang on. So this is not your anterior tooth. Typically this is anterior teeth because the occlusal forces on the posterior tend to be pretty tough to ever retain these guys. But anterior teeth before implants, when we didn't want to just destroy the other teeth, we were able to do this little guy. We got pretty good aesthetics with it. Everybody knows that Tom Cruise has that anterior crown, right? It's better now than, so go back to old movies if you're okay with that guy. And pretty weird. He has this anterior crown that who knows how many he's had and how much money they've spent on it. But, you know, it's still, in the beginning, it was like, yeah, dude, you have a crown. So they're hard to match. So in this case, if you completely lost the tooth, it gave you some better aesthetics. It is not the I'm biting my carrots off on those 3 teeth thing. You're going to chew on the other side. But it was better than what we had as far as putting a partial in there or a bridge that would look different. Question?
Could we use our ultrasonic on the pontic?
You would generally not have to do ultrasonic on the pontic because, yes, they can get calculus on them, but it tends not to be very adherent at all.
Okay.
And what happens if you slip with your ultrasonic on the lovely pontic? It'll scratch it or etch it. So you want to be really nice to that material.
What about underneath the pontic? Like accumulation underneath it?
Yes, totally happens.
Totally happens?
So what are we going to do?
We're going to clean it out.
Yes, and you're really going to focus on around the margins of whatever abutment teeth that you have, or really carefully cleaning the implants. Right? So, abutment teeth, we already had to saw these guys down. We have a crown margin, so now what? How worried are you? Be worried. Please be worried. If they have bridges, I expect fluoride to happen on there. Right? So, and then we're going to really work with them on their oral hygiene. So what's that going to be? Interdental aids. And then to get right underneath the pontic, what's really good? What kind of floss? The thick floss, the fuzzy floss if they have space. And bridge fitters would be ideal because then you can sweep underneath there. All right. So, denture first. Non-abrasive. If they have exposed roots, we don't want a lot of abrasion on those roots. We're going to do fluoride containing because we've got to protect the remaining teeth. If they have exposed cementum, that's way softer than the enamel that we lost, right? So we really got to be on those things. The APF will etch stuff. So if it's white, that's not right. If they have a full gold crown, APF, not a big deal because it's inert, it's not going to etch. But anything that is porcelain or composite, that can be etched. Glass ionomer, all those things can be etched by the acidity. So here's our spot now with taking care of these guys. If it is fixed, that interdental care is super critical because that pontic actually will block out a whole lot of their oral hygiene efforts. You will commonly find, lunch and like yesterday's dinner and stuff under there. Okay? So we're going to really work on cleaning under the pontic on the abutment tooth surface. And we are also going to think about flossing, but not way down into the gum tissue. We're going to try to floss up underneath or above, whichever maxillary mandibular, that tissue side of the pontic. And the way we design bridges these days is way different than back in the day. So in the 40s and 30s, you have this gold crown and we really need it to not have all that debris under it, so we're going to make a saddle shape. You've seen the saddle chairs, right? Think about the saddle sitting on the back of the horse. Picture trying to get floss under that. It's not happening, right? Because you'd have to cut through the bone that's on the ridge. Yeah, it's not good. So they finally figure out, that doesn't seem to work. Well, these patients get a lot of decay. So, okay, to protect that, we're going to really put the pontic, so we won't do a full saddle, but we'll do a half saddle. Right, so now, unless they're super coordinated, now they have one half that they have to go way down in the vestibule to try to clean underneath. Now they tend to do, and for a while there was we're going to just sit that down so we have good aesthetics and it looks like it's sitting in the tissue. So that was fun to floss around, but less bad than the saddle. So now they tend to have fairly close proximity to the ridge, but enough room so you can get some floss in there for sure. Way easier. And they opened up the abrasures compared to what we used to see. You can usually get a teppy brush or something in there. So that's the thing. Ideal would be bridge threader and really good floss, but if they have enough recession that the interproximal concavities are exposed, then we're going to talk about a brush instead. So we want a teppy brush or something in there. The soft picks are usually go in there and help it fill in and get into those little concavities. We're going to go by what is your access, what's the contour of the root surface that's exposed, what's the patient's dexterity and motivation. All right, removable partial. So they have a chrome cobalt framework and they attach to abutment teeth. So similar to a fixed bridge where you have abutment teeth that are holding these guys in, we still have teeth holding these in. So we have clasps that come around and hug the teeth. We have little occlusal rests that help take the biting forces so that it's just not shoved into the tissue. It's actually going to rest on the teeth and the teeth roots will take up some of the stress. We can have precision attachments. So down here, take a look I don't know if you can see this picture on this or on your laptop better, but if you look at this bridge that they have put together, these are actually all attached together. So very, very demanding to do these guys. And then the crowns that the canines have little cutout ledges on them. And they also have this little attachment that hangs off the end. So it's the dovetail part of the dovetail. And then here are two little areas here on the denture, the partial denture, that come over and slide down onto that dovetail. So these are the little keyhole guys that actually accept the dovetail and help lock this denture onto these teeth. And then the canines are taking up a lot of the force. How much do we care about the periodontal health of these canines? A lot, right? So we're going to be really careful with them. Now we have all of these crown margins, so we're really, really concerned about caries as well. We've got to keep these teeth so they keep this denture. Yeah?
I'm a little confused on how that fits on the other one. Because how is it going to hide the shiny part?
So this is on the tongue side.
Oh, okay.
It's just going to rest right on this lingual.
So just...
So the tip of their tongue is going to be covering that most of the time.
Okay, so that's lingual and it fits. Okay.
So we're going to take this and just go.
That's maxillary.
This is mandibular.
That's mandibular.
Right,
Okay.
so this horseshoe is going to come over. These sit on the ridges here.
Yeah.
And then these little sockets fit over these little precision attachments.
Okay.
That is.
Yeah.
So, rests like this, or these little ledge guys. Here's a little rest that goes on the cingulum of the tooth, so that would be these little notches in the canines. So sometimes they'll actually do this if the patient doesn't need crowns. They'll actually cut a rest into an existing tooth. It's like, oh, what happened to this tooth? We did that on purpose. We made a little rest on that tooth to be able to accept the denture. Okay, so we talked about the health of the supporting tissues can be compromised because of heavier biofilm accumulation around the abutment teeth and the denture. So we really are responsible for educating the patient regarding their increased risk. Identify those specific needs, examine that tissue really carefully around all those abutment teeth, either for a fixed or a removable prosthesis. Really be cautious, vigilant about looking for and identifying decay or decalcification on the abutment teeth, and then recommend medicaments as needed. So fluoride, MI paste, and if they're really bad off, then we may need to do chlorhexidine for a time. But they can't live on chlorhexidine. But we may use it if we have an urgent need for a time. We're going to check, are your dentures or partials comfortable? Comfortable-ish, real comfortable, what are we thinking? Do you have problems eating, drinking, speaking? Do they fit securely? Do you have any sore spots or any places that are irritated? And then look, right? Because the patient may be just like, yeah, whatever, it's what it is. Look in there and see if you see anything that's irritated. How often do you take them out and for how long? So remember, rinsing, just like on your teeth, is not going to take care of our problem with biofilm. Got to remove it using brushing, ultrasonic here, some other method as well. Even putting them in the ultrasonic here does not take the biofilm off. You've got to brush it off. But we've got to be careful to make sure that a couple of strategies. Remember we said washcloth in the sink. You can also put water in the sink just to prevent breakage, because eventually they'll drop it. There are the big denture brushes we have. We don't have clasp brushes, but you can recommend the patient go get a clasp brush. So it's like a mini bottle brush, and these little clasps hug around the tooth. So if they're not cleaning the biofilm out of those, then every time they take it out and they clean their denture without brushing in there, and they put it back in, oh, here, this biofilm never went away. It's nice and mature, and it's just recolonizing like crazy. Happy, happy biofilm. So we're going to make sure that they can reach all the areas of their tooth, of their prosthesis, with a particular brush that's going to work to get all that biofilm off as much as humanly possible. We're not going to use a regular toothbrush or an electric brush, because that can damage the brush and it can also damage the appliance. Here's what happens when you put the metal in bleach. It completely oxidizes it, so ugly, uncomfortable, destroyed. So yes.
Could you use normal toothpaste on dentures?
And we're not going to use normal toothpaste because it's a little abrasive, and we don't want abrasiveness on the tooth, on the partial or denture. And alcohol, oh, I'm melting. Right? So there's my $2,000 and plus the fun of doing it. Yeah.
So can you use MI paste, or is that still a little too?
So she was asking about to clean the
Just
denture.
regular toothpaste, or is MI
So
less
around the
abrasive?
teeth, the MI paste you actually would apply with your finger, because it's just really an application versus a brushing.
Okay.
But around the teeth, you want to be as non-abrasive as you can. And then around on the removable prosthesis, you're going to use something specifically formulated to that, because that we don't care about fluoride, right? All right. So we always want to take the appliances out at night to allow those underlying tissues to rest and actually get oxygen to them. So if you put your shoes on, you wear them for 6 months, how would that go? Right? So, you want to make sure, so now my patient who was wearing his partial at night to avoid having issues, or his denture at night to avoid having issues with grinding, because he had lower anterior teeth and he would grind up his palate without them. He then, after dinner, took his partial and his denture out, and he left them out for as many hours as he could, put them in for bed, left them out then earlier in the day. Somebody had a question.
Does this all apply for like retainers?
To a lesser extent, but yes.
Because
So obviously you have to wear them at night, and in the beginning they're like, wear these 24 hours a day, right?
and they can
Younger people, juicier mouths, not so many attachments, right? So more resistant. But if you leave it in there long enough, and especially you had ortho as an older patient, this can happen.
Because I actually clean my retainer with lime away.
Yes. So stainless steel wire, so you can get away with it. And then you just rinse the dickens out of it, right? Because nobody needs to have that acid peel out of their mouth. Hydrogen peroxide is not going to really damage it, but it's easier to just use a cleaner that's meant for the denture. All right, so here's what happens. You'll have the patient take this denture or partial out, and you're going to see this red, velvety, or bubbly tissue underneath. So often we can fix this by just having them take it out enough. But this usually means candidiasis in there. So if they have reasonable resistance, when you get the denture out of there enough times and you clean it really good so you're not just reintroducing the candida every time you put it back in, they'll recover from this. But there are times we have to do meds for this. Always keeping the appliances in water overnight, because if the acrylic dries out, it distorts. So you always want to do that. And guess what? If it's sitting dry on your bracket tray for 4 hours, it can warp. So you're always going to keep it in water during the appointment too. We're never going to put it in hot water. Oh, get this good, hot water. No, we can actually warp it. Okay, obturator. So cancer, cocaine abuse, that's really pleasant to. So cocaine, the only vasoconstricting local anesthetic, right? Vasoconstriction, 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 over and over and over and over and over. No blood circulation, necrosis. Okay, so this is probably a cleft palate. I would love it if they would move this, canine, but that's my ortho assistant thing. Because then we could put an obturator with a little tooth on there, but okay. Right, so this is an obturator that has a little kind of bubble of acrylic that is softer, and it just snugs into that little void so that they're not getting their food and their liquids up in their nose all the time. Got to have this thing cleaned daily. Depending on the defect, they might need to sleep with it for comfort. So then this is the kind of thing where it's like, okay, as much of the day as you can, leave it out. But obviously, if you lost a whole chunk of your maxilla because of oral cancer, you're not going to go out in public without it. And remember, any of these removable things, they're removed when you take x-rays, yes? Because everybody will take one picture with the partial in, and then they'll go, oh yeah, never doing that again. Yeah. Always look before you leave. So again, immediate denture placed at the extraction appointment, reline or rebase at least by 6 months once that bone recontours. But typically they put a soft liner in it and you reline it and you reline it and you reline it with that temporary soft liner as the tissue is resolving, recontouring, and the bone finally gets to a point where it's pretty healed. Then they take all that out and they put the permanent liner in. A conventional one is the patient's already missing their teeth and we can just directly take an impression of the ridge or the palate and get a good fit there. Oh my gosh, having implants, if you've lost all your teeth, makes a huge difference. Mandibular anterior implants in being able to bite. You can actually bite the apple. It's not great, because it's maxillary denture often, but it just gives you so much force to be able to actually bite. Because you get that biting force, that 10-fold decrease, you can get a chunk of that back. So sometimes there are little precision attachments on the denture and the implant. And so these guys will kind of snap over this bar, or they actually have either a little ball and socket thing, or there's a little thing that goes down into the implant on the denture. Or if they have a fixed one, this actually has little screws that screw in the top of the implant. Oh, wow. Right? And then if something happens, we can actually unscrew it, deal with it, put it back. But oh my gosh, you have to take care of these. So these are natural teeth. They've had endo. Amalgams tend to seal better than composites, so they have amalgams in the little access hole that's left. We whacked off the crown. All we have is root. Right? So way softer than crown. So these are exquisitely vulnerable to decay. They've got a little hole in the bottom of the partial that is awesome at retaining biofilm. But this is what we did before implants, right? Okay, you at least have these canine roots we can hang on to for dear life. And so they've got to be really good at brushing around them. N-tuft, in my experience, is usually the best. The little yarn floss, you would think, oh, one little nub, well, how hard is that to clean? Really hard. There was a question.
Did they
the fixed implant full denture? Because they don't remove them like every night.
So it depends on how it's designed. So they're not going to have direct tissue contact generally, but it may be really hard to get underneath there. So it'd be more like a fixed bridge kind of infection.
How does the tissue break?
So this does not rest down on the tissue when it's correctly designed. It's a couple of millimeters above the tissue or below the tissue. Do you have breakfast, lunch, and dinner in there by the end of the day? Yes, you do. So bridge, threaders, and really furry floss to get all that stuff out of there. Okay, this is a little overkill. Okay, we need 14 implants. They'll do like 3 here and 3 there more these days to be able to hold a maxillary denture. But the mandibular implant supported one would be the more common. Okay, so, oh my gosh, fluoride, 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 fluoride. If there's natural teeth, fluoride. We don't need the fluoride with implants, but oh my gosh, now we're talking implants, risky. Oh my gosh, don't fail. So, fluoride denture mouth rinse, home gel tray, any chance you get to put fluoride in this patient, do it. They need it. In the overdenture case, we can actually, in the little holes that accept that fit over these teeth, these remaining teeth, every single day I would have my patient put little drops of fluoride on there, put that guy in, custom tray, hold the fluoride on there as much as you can. We can do sealants over the surface to reduce caries risk, but just anything you can do to make that better is important because they're really common, they decay. Okay, denture base holds the teeth and is actually the part that rests on the mucosa. The impression surface is just what it sounds like. It's the surface that we took the impression of the tissue, and now we've replicated that impression in this surface. The polished surface is the facial part that hopefully looks like real gum tissue, like it matches the patient's normal coloring, and is a reasonable contour and all of that. They actually put little fibers in there to look like little capillaries. The occlusal surface is actually where the teeth are making contact with either other natural teeth or another prosthesis. The teeth are generally these days acrylic or composite resin. Sometimes they use porcelain teeth. How hard is porcelain? Really hard. How resistant are the teeth to the porcelain? Not very. So if they have porcelain teeth opposing natural teeth, you can get a lot of wear on the natural teeth. So we generally do acrylic or composite resin teeth because the teeth will wear on the denture teeth. The natural teeth will wear on the denture teeth. We can replace the denture teeth every several years. We don't want to try to repair the worn down natural teeth. For somebody who has a very difficult time chewing, they'll actually sometimes put little metal surfaces on the molars that are like little mincers, dicers, slicers. It makes my tongue hurt thinking about it if you slip, right? But for some people that just helps their chewing efficiency enough they can cope. I've seen a couple of patients over the years that had those. That's not super common. But it'll be this little metal grid kind of sticking out of the tooth, like, oh, what is that? All right, denture adhesive. Okay, so fluoride toothpaste, we're going to do the big cake swirl. No, we don't want to do that. Denture adhesive. The ads make it seem like every single person who has dentures needs adhesive. That's actually not the case. You should not need adhesive to hold a well-fitting denture in. That should be a temporary situation. We're on our way to a new denture, or your teeth you have the immediate denture and you're going through your remodeling of the tissue, and temporarily you need to use adhesive to make it better. Or you just got the denture for the first time and you feel like you have 2 frying pans in your mouth and it helps if they're glued in. Right? So, it should be a short-term thing. It is gloppy, gluey, messy, horrible. I can look at a lot of stuff. Sometimes when the patient would pull out the big giant wad of adhesive, it was like, excuse me, let me turn away here while you handle that. It gets easier to take off if it's been there for a while. If the patient puts their denture back in before the boss gets to come and take a look, and then they have to have all this stringy adhesive. So kind of babysit the denture yet, not yet, because it's just a big pain to get off their tissue and get off the denture because it's super sticky to be able to do a good exam with it. But they have got to get that stuff off every day. If they are using it, it's got to come off every day. They used to contain a fair amount of zinc, and patients who were using a lot of it, and especially over a long time, would get OD'd on zinc, and they started seeing patients with peripheral neuropathy related to zinc overdose. So if you look at the ingredients, zinc is not in there anymore, but just something to be aware of. So there's a little medical devices products and stuff from the FDA about that. All right, what gets on these dentures? Food debris. There will be food. Pellicle and biofilm. There's kind of denture breath. It's really, really special. Denture stomatitis because of the biofilm. Calculus can form on it. Where is it usually going to form? Somewhat around the crust. What teeth? What do you know maxillary first molars, mandibular anteriors? Because salivary glands. Okay? They're going to stain like natural teeth. So tobacco, red wine, coffee, tea, that's all going to stain them. Don't assume the patient knows proper care. Right? So you have the patient who's really had a tough time already because they lost their teeth. So they may be listening like that, yeah, whatever. Or maybe they just never were taught. So make sure that you check on what they're doing. So we're preventing oral lesions and irritation. We're going to try to control infection. We're going to prevent odor. We definitely want to prevent increased infection around the existing remaining teeth. They've got to rinse after every meal. Just go somewhere, rinse that guy out. And absolutely brushing and soaking at night. You've got it every single day at some point. Chemically immerse these guys in a cleaner overnight usually works the easiest. All right, so when they're rinsing, we're going to do a towel or washcloth in the sink to prevent breakage. When you're immersing, you're going to put a solvent that reaches all the areas, but it's effective. But that's only going to be effective on the loose debris and the stains. So you can use bleach if you have no metal. And so people will sometimes homemade put a solution of bleach, water, and Calgon water softener that's going to help break down the calculus. And I had a boss that was fairly thrifty, we'll say, and we actually had to mix it up ourselves in the office. Worked pretty well. Can be soaked for 10 to 15 minutes in that, but then you're going to rinse it really carefully before you insert it. If somebody has a terrible mess and they don't have problems with the metal, then yes, you can use lime away, but rinse, 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 rinse. And that's not something I would normally tell a patient to do. You're going to hold this denture really carefully, again, over the sink with water, towel, right? We're going to do a towel because we don't want water in the sink because we can't get the sink sterile. You're not going to smush it, but you're just going to be really secure. So it has the denture brush is going to have a flat brush area, and that goes on the outside of the denture like a toothbrush. And then this little thing is pointy trim. So on ours we have this side's pointy, that side's flat. Sometimes they're in a row like this. The pointy part goes into the ridge area so that you can actually access all of that. Always taking them out at night, let that tissue rest. And always water during hygiene appointments, no hot water. Again, you can use toothpaste and powdered, or I should say denture cleaning agent, pastes and powdered cleansers. Should be really low abrasive. Some patients will use mild soap, like ivory soap, to brush them. That's fine. But I also had the neighbor when I was in hygiene school who was the landlord at our apartment complex that I said, we're looking for patients. Go ask everybody you know. You need to screen people and bring your patients in. Do you need any dental care? Would you like to come in? Oh, mine are all good. He pops out the denture, just a little comment. Oh, that's why your teeth are that abraded. Okay, I'm glad it's not natural teeth. So, what lesions do we see with these? We see denture stomatitis. So that's that inflammation of the oral mucosa, swelling, redness, pain. Papillary hyperplasia, in addition to that, increased tissue because it's just reacting to that irritant of the biofilm. Chronic candidiasis, they can have long-term, really hard to get rid of. Here's the cruddy denture. Here's why it's not happy underneath that cruddy denture, it's red. So denture, sore mouth, not really painful, like sharp pain, but just really irritating. 20 to 40% incidence of the in the edentulous population. And if they're older, they wear a complete maxillary denture. They're pretty doggone high risk of this. This is papillary hyperplasia. So not only is that inflammation and hyperplasia, but see how it looks bubbly? And that is really typical of candidiasis. So if you see the bubbly thing, unless you can see them in a week and they really have left the denture out and they're really way better at cleaning it, and you see significant resolution, this is the patient you're going to have the boss write a prescription for an antifungal. If they have a soft tissue conditioner liner, we want to try to take that out if it's old. If they're having pain from this, we want to put a new one in because ouch. And if it gets bad enough hyperplasia, we may need to actually do a little surgery to remove the overgrowth. Right? So we don't want to let that go on. Plus it just hurts. And so this is the chronic candidiasis. So what do you know? They have denture, sore mouth, and this is the papillary hyperplasia, and it's all related to fungus and yeast in there. So we treat this with nystatin, they rinse with it, and then they swallow. So they're getting topical treatment plus oral, systemic. And then obviously we're having them clean that partial denture exquisitely clean, the best they can every day. Otherwise they're just it's just reinserting it all the time. Here's the other thing. So we said loss of vertical dimension. What happens? The corners of your mouth start to fold over and you get this little area, whoops, that's chronically wet. Chronically wet spots, what do you know? Get yeast infections, right? So, can you send the patient to the foot care aisle? Yes, you can. To do a little topical antifungal here. The pink tacks, don't send them to the ladies section. Send them to the foot care section. You guys know what pink tax is?
What?
How much does your haircut cost? How much does my haircut cost? Pink tax. Okay, so if it's for women's parts, it costs more. It just does. Okay, so this is probably colonized with bacteria as well, but definitely fungus. You can also get this kind of thing happening because of vitamin B deficiency, and it's a whole bunch of different B vitamins. So you're also going to do nutrition counseling with this patient. And we've got to get through denture cleaning, same thing. Yes?
Oh, not stretching.
Okay. All right, Epulus fissurata. I'm sorry, this is not a great picture. I could not find some great pictures. I'll be on the search for the next year. So, denture fits in this little fold. So there's a fold of tissue here and a fold of tissue there, and the flange of the denture is fitting in there. And it has these little flabby bleh that come around it because that denture flange is really irritating the tissue, and then the tissue is going, oh my God, try to cushion this and make it better, stop. Right? So it's an overgrowth of the tissue. You got to adjust the denture, probably make a new one, and then something this big's not going to resolve. They're going to have a little surgery or a medium surgery. Okay, so what are we going to do? Yeah, you know, your gown, your eyewear, your mask. New denture brush, new plastic cup, 2 pair of gloves. Let's see, is this? I actually have a better version of this, so never mind. We're going to talk about this afternoon. And hopefully I'm making a video in the next 10 minutes with Ms. Withers and post that. Questions? Angst. AM, PM, people.
The assignment?
Yes.
The assignment? That's due next week?
Yep. Go shopping. Sorry, it's not a fun trip, but it'll be interesting. Okay, so I'm waiting for my 2 chart numbers for my folks tomorrow, and is there anybody besides Noe and Catalina whose first adult prophy is in the morning? Okay, so write down those 2 things. Who else was talking about morning for their patient then?
What you said to be the morning,
I'll find out for my.
the first adult prophy.
Can I give them an opportunity or should I just have?
Let's not rock the boat because you have 4 hours in the afternoon and only 3 in the morning.
That's true. Cool.
Let's not rock the boat. Okay, so Sarah, sounds like you're wide open for either morning or afternoon, whatever's gonna work. But I'll just double check with let's double check with Ms. Lee because I think you should be able to see your adult patient. We could talk about that. Okay. Any other issues with tomorrow's clinic that I want a heads up on fixing? We're good. Okay.
I wasn't able to pull up Axiom, but I'll go talk to Jeanette right now and get that. And then can I just give it to you during lab? Okay, perfect.